Stream has started, Chair.
Thank you. Okay, good morning, councillors, officers, members of the public and press. Welcome to this meeting of the Health and Wellbeing Board. This meeting is a remote meeting and it's being live streamed on the website and recorded. I'll now hand over to the Democratic Services team to conduct a roll call.
Thank you, Chair. As indicated by the Chair, we will begin the meeting by way of a roll call of all those in attendance remotely. May I request all to confirm they have a paper copy or an electronic copy of the agenda and can both hear and see the meeting. Now begin the roll call with Councillor Buchan.
Yes to all.
Thank you. Councillor Moore?
Yes to all.
Councillor Thomas?
Yes to all.
Councillor Ward? I'm not sure if Councillor Ward's joined the meeting as yet. I'll come back to Councillor Ward.
Yes to all.
Oh, sorry, you have joined Councillor Ward. Thank you. Dr. Timlin?
Yes to all.
Thank you. I understand Karen Hawkins is substituting for David Gallagher.
Yes to all.
Thank you. And Craig Blunderwood?
Yes to all.
Thank you. Sally Robinson?
Morning, Amanda. Yes, I've got everything. Thank you.
Thank you. Jill Harrison?
Yes to all. Thanks, Amanda.
Thank you. Margaret Wren?
Can you hear me?
Yes, we can now, Margaret. Thank you.
Thanks.
Thank you. Denise McGuckin?
Yes to all. Morning, Amanda.
Thank you. Tony Hanson?
Morning, Amanda. Yes to all.
Thank you. Danielle Swinston?
Yes to all.
Thank you. Dr. Butler? No. I understand Sandra Britton is substituting for Tracy Woodall.
Yes, I'm here, thank you. And I have all the papers, thank you.
Thank you. Dominic Gardner?
Hi, I'm here. I'm not sure what I'm saying yes to all, though. Apologies, I've joined a little bit late.
Okay, we were just checking that you've got all the papers. Thank you, Dominic.
Yes, sorry.
Yeah, thank you. From the police, have we got Chief Inspector Peter Graham for Sharon Cooney? No. Fiona Adamson?
Good morning. Yes to everything. Thanks.
Thank you. Sonia Black?
Morning. Yes to everything.
Thank you. I've got Deepak from the North Tees and Hartlepool NHS Borough.
Yep. Yes to all.
Thank you. And Councillor Hall? Sure, Councillor Hall's joined us. No. Can I just conclude by asking if there's anybody else in attendance that I haven't already included on the roll call?
Yes, Brenda Harrison.
Oh, thank you, Councillor Harrison.
Also, Councillor Tony Richardson.
Thank you, Councillor Richardson. And I think Zoe Sherry's here representing the Hartlepool Mental Health Forum. Is that correct, Zoe? I think you're on mute, Zoe, but I think you were there. Thank you. That concludes the roll call then, Chair. Thank you.
Thank you, Amanda. Can I just ask before we go any further, just because it causes an awful lot of feedback, unless members are actually speaking and you're about to speak, can you keep your microphones muted, please? Because it does cause an awful lot of problems. Thank you. I noticed, sorry, Amanda, during the roll call you mentioned Chief Inspector Graham. Although we haven't had any apologies for this particular meeting, I do know that Chief Inspector Graham is currently on secondment over at the control room, so I would automatically assume we would have his apologies because he isn't in his usual role at this point.
Okay, thanks. We'll note those apologies. Thank you.
Thank you. Okay, are there any other apologies for absence before we go any further? Okay, declarations of interest.
Chair, can I declare my usual interest as a employee of Health Watch Hartlepool?
Yeah, thank you, Councillor Thomas.
Can I as well, Shane, just declare my interest because I am an employee of Hartlepool Hospice. This is the house.
Thank you. I'll have to state at this point, for whatever reason, my participant list isn't working correctly, so I'm not seeing any raised hands. So if somebody could just assist me with that, that would be quite helpful. Thank you. Are there any other hands raised for a no? Thank you. Okay, we'll look at the minutes for the meeting held on the 7th of December 2020. Are there any questions or comments on those minutes?
Shane, just a quick point. Your video camera isn't on. I'm not sure if that's purposeful or not.
No, it should be. It should be on. And you're only getting my lovely voice and not my beautiful face too.
Just seeing a big S.
No, right. Just bear with me a second. We'll see if we can fix this.
I can see you, Shane. So I don't know if Deepak's end. So
no, I can't see you either. I'm afraid. Yeah.
Neither can I.
Right.
Just his photo.
Oh well, it's a good photo anyway, so I'll take that one. As long as I guess that as long as the stream is working, and we would have been told by now that if it wasn't, we should be all right. Okay, if there's no comments from or questions from the minutes of the meeting on the 7th of December, can we take those as a true record? I see no dissent. And then we have the meeting notes from the Outbreak Control Engagement Working Group on the 10th of November. Again, any questions or comments on that one? If not, we'll take those as a true record as well. Brilliant, thank you very much. Okay, we move on to agenda item 4.1, the Face the Public event, and that is being led by our Director of Public Health, Craig Blundred.
Thanks, Chair. Just as I was quickly whiz through the paper in front of you, it's a requirement as part of the Constitution that the Safe Hartlepool Partnership and the Health and Wellbeing Board hold a Face the Public event each year, and that's primarily to update on all of the work during the last year, inform residents and elected members of our future plans, challenges, and consult and engage on the development of strategies and plans, as well as receive questions on the work, future plans and priorities. These have all been held annually with the exception of last year, which for obvious reasons during the COVID pandemic saw the cancellation of the Face the Public event. Obviously, at the moment, we are still working within restrictions and the ongoing pandemic. So we need to start to think about what we would do this year for a Face the Public event. And after much discussion and contemplation, we've decided that we are going to ask the board to approve these initial proposals, which are outlined in the paper, which will obviously meet the requirements of the Constitution, accommodate our election and purdah period, which we're about to enter shortly, and also take into account, how the pandemic is actually panning out and working with the uncertainty around that and where we were likely to be in terms of the recovery. So our proposal is that we do have a Face the Public event purely for the Health and Wellbeing Board. Previous years it has been held jointly, I think, with the Safer Hartlepool Partnership, but we propose to hold a single one for the Health and Wellbeing Board in September 2021 and conduct that in a remote way so that we maintain COVID safety whilst we're doing that. So the structured purpose of the event will follow the priorities that we looked at 2019, is where the time goes when we're in lockdown. And that looked at the priorities which were approved last March. And the priority areas are the impact of violence, including domestic violence and drugs and alcohol, maintenance of a universal offer for the whole population, and the development of a targeted place-based approach, which widens the work being undertaken by the Council's Children's Services Department around streets in the Victoria Ward. Obviously, progression of all of these priorities hasn't happened as quickly as we would have liked, clearly because of the pandemic and the restrictions and also the work being diverted to that. But we hope that the Face the Public event will provide us the opportunity, hopefully by September, to start thinking about how we restart the process for those priorities and also fulfill the requirements of our Constitution. So that's the recommendations. Recommendations are that we approve the arrangements as outlined in the paper, and that the delegation of the arrangements for the event is delegated to the Director of Public Health in conjunction with the Chair of the Board. Thank you.
Thank you, Craig. I'm pleased that we're going to be able to move forward with this year, because not only is it important that we continue with these Face the Public events and get vital feedback from the residents that we all serve, but also because it finally means that we're hopefully going to be able to start working on the proposals that we all came to, well, like Craig said, back in 2019 now, and that we agreed, because I think we did select a really good sorry, my mind isn't working today. We set a really good working arrangement moving forward about what we wanted to target, and specifically that targeted approach in the certain areas and the things that we know cause such problems in our communities. So, and I know Councillor Harrison will be very pleased to see that the consultation is going ahead as well. Councillor Thomas.
Thank you, Chair. Like you, I'm very pleased to see these priorities being taken forward. I think I would absolutely agree that they are all very important areas of work, and topics which possibly have been on the back burner to a greater extent than we would like to have seen because of the pandemic. And I think that they are an excellent choice of areas. I think the thing that I would add, though, is that perhaps in parallel, there needs to be, I think, something around starting to look at the longer term effects and implications of COVID moving forward. And I think that perhaps could be something that is separate to the Face the Public event. But again, thinking about things that we discussed on Thursday at the full council meeting, some of the implications, particularly around mental health and wellbeing going forward. I do think that as early as possible, the authority and partners need to be considering some of those longer term implications of COVID as we move through lockdown, move into hopefully back into a much more normal society. Those implications from COVID are going to be with us for some time to come. And I think we do need to be thinking about that strategy, whether or not it's linked into a Face the Public event or whether it is an independent work stream. I think it's probably open for debate, but certainly I think at this stage we need to be thinking about how we do that going forward, because I think, as we all agreed on Thursday, the implications from COVID and the long-term effects both for individuals and our communities are going to be with us for many years to come.
Thank you, Councillor Thomas. I mean, I completely agree with you, and if I'm being honest, it's a piece of work that I would prefer to see as an independent work stream, simply because it's going to take an awful lot of attention and it's going to need some decent resourcing as well. So I'd rather us absolutely focus on it as opposed to it being a bolt-on to another piece of work. But I don't know how you feel about that.
Yeah, I absolutely agree with that, Chair. And I think the point I'm making is that we are at the stage now where we have got to be given some real serious thought as to how, as a council, how as a health and wellbeing board, and how as a group of health partners, we start to look at some of those longer term implications and make sure that they are built into our planning processes at the earliest possible opportunity. I think you're right, it does need to be an independent work stream, but I just think it was appropriate probably to flag it up here.
Absolutely. Thank you. Councillor Harrison.
Thanks, Chair. Yeah, you're quite right, Shane. I agree with what you've said. And I think that Stephen's dead right as well. I'm going to just highlight a couple of areas because this pandemic has exacerbated some of the underlying issues that we've had for years. And, you know, it's no good going back to that kind of stream and thinking that we can put all that right, because it's actually worse than it ever was. So we've got a situation, for example, in fostering and adoption, where there are more children coming in to be fostered or to be adopted. and therefore there are more families that are vulnerable. And we've got to address that as soon as possible, because otherwise it's just going to get worse and worse and worse. And I think it's a long way down the line, as a number of issues are. And I know we all realise that, but it's really a priority. Thank you.
Thank you, Councillor Harrison. Dominic?
So just picking up in terms of Councillor Harrison's comments, and also particularly Councillor Thomas's, people will recall that we did the joint presentation in terms of the impact of COVID in terms of mental health and well-being in the meeting just before Christmas. But I think it's probably timely to put some meat on the bone of that in terms of an actual plan, in terms of what it is that we're going to be doing about that. And I wonder whether we kind of channeled through some of that through the Mental Health Forum, so that we've got a group that could potentially have oversight and start to develop that. But then we're clear that obviously in terms of well-being, it's a very, there are multiple factors in that impinge in terms of well-being, so we need to have far broader engagement. But I just wonder if that would be a starting point to be able to take things forward in terms of the issues that Councillor Thomas has raised.
Personally, I think that's a great move, to be honest. I don't know if Councillor Thomas wants to come back in, since he raised it first of all, but I'd be pleased with that. Fiona?
I was just going to say absolutely agree with what Dominic said, and also what Councillor Thomas raised. And just to offer support, I think in Hartlepool, one of our strengths is relationships. And I think we have a really good relationship with the voluntary sector, with growing social prescribing team. I think there are a lot of people who could get involved in that work and make a difference to it. So I was just volunteering support, really.
Great, thank you. And Councillor Thomas.
Yes, Chair, absolutely no problem at all with Dominic's suggested course of action around mental health. I think channeling that work through the Mental Health Forum is absolutely the reason why the Mental Health Forum is there. And what I would say the Health and Wellbeing Board is having going forward is that sort of oversight and coordination role, because it isn't just mental health. I think it's every aspect of health and social care has been impacted upon by COVID, and there is going to be an awful lot of consequences, not just around mental health, but in every area of health and care. So I think similar sorts of streams I would anticipate coming through in all of our health partner areas, and from time to time reports and feedback coming through to the Health and Wellbeing Board in its sort of like strategic coordination role that it has.
Okay, thank you. Are there any other questions or comments, or can we go with the recommendations as set out in the report? And obviously, we'll be working as a board around the wider. Sorry, it really has been a long morning for me today already, about the wider impact of COVID moving forward, and particularly working with the Mental Health Forum and creating a new workflow around this. Any dissent? Great, thank you very much. 4.2, so we've got a couple of COVID-19 updates, and the first one again will be from the Director of Public Health, Craig Blundred.
Thanks, Chair. I'll just see if I can share the presentation. Fingers crossed. Although it does seem to be, I seem to have lost most of the video on the link. So hopefully, no, this is going to work. Can everyone see that now?
Yes, thank you.
Yeah, everyone can see that? Great. I was wondering if there's anyone there then for a moment. Okay. Just check that's working now.
Yes, it is.
Yeah, brilliant. Great, thanks. Yeah, okay, so you'll be probably all now be familiar now with my regular update on the COVID-19 situation. And what I'm going to do today as well is we're just going to take you through the current figures and numbers, and then give an update on where we're actually at with some of the initiatives we're implementing and have been implementing over the last, well, obviously now a year now. Given how long we've been in the situation, and as I say, it seems to have been quite a long year in terms of dealing with this. And I think if you look at the case rate there, which shows you the England and Hartlepool overall case rates per 100,000 over that time period from when the COVID pandemic first started, I think you can see that it's been quite a challenging year for Hartlepool, given the fact that we've had a much higher case rate than the England average figures there, which is shown on the graph there. Again, as I keep reiterating, it shows that we went into it quite later on than certain areas, but then it has exceeded the rate sort of early on, around about sort of May time. And there's a variety of different reasons for that, including things like structural inequalities and health of the population. But I think it's quite telling to see that figure there. Just to bring you up to date with the case numbers, you'll have seen the peaks and troughs before, and the graphs on the top there show the England picture, and the graph at the bottom shows the Hartlepool cases. I think you'll find we did have over the Christmas and early January, we were at our highest rates, going up towards 800 or cases per 100,000 for a 7-day period, which was a significant proportion of cases. I think what you can see there at the right-hand side of the graph is that we've come down quite significantly from that in the lockdown period. In fact, we've come down quite rapidly in terms of the numbers. We're down to around about 168, and I think we possibly might be a little lower than that when the figures are updated today. I think what we have to say, though, is whilst that's been a brilliant achievement by everyone in the borough, we're starting to see it slowing down, that decline. And I think that's one of the worries for me at the moment as we start to head towards coming out of lockdown. We wanted to get the figures well below 200 per 100,000, which we're working towards there with that figure, but it's still quite high, or it's still very high. In fact, we really need to be getting down below 100. I think some areas in the northeast are starting to see that, but our numbers are starting to flatten off. It's very similar across the rest of the Tees Valley, but our sort of partners further north are seeing sort of higher levels of reductions than we are. And I think there's a variety of different reasons for that. Again, going back to things like structural inequalities and various reasons, and we are doing some work to have a look at a deep dive into why this might be the case, particularly across the whole of the Tees Valley. And there are some interesting points that have come out, given the work we've been doing around tackling the high level of cases so far. But I think we can't relax. We can't be getting complacent, because that's still far too high for the numbers. Deaths, I think one of the things I've noticed of late, the deaths have started to level off. Again, we've got higher death rate per 100,000 than the England figure, but we have started to see fewer coming through now, and I think that's reflected, I think, in as well in the reduction in people being hospitalised as well. So I think there's positives. We are starting to see some positives, and there is light at the end of the tunnel. But again, going back to the fact that our rates are still higher than we would want them to be, we can't relax our guard at all at the moment. So again, with the usual sort of maps that show where the cases generally are and the density of them. And again, we don't see anything that we wouldn't be expecting to see on these, in that they're around the main areas of population. And we do follow the cases quite closely in terms of understanding the spread and understanding where cases crop up from, and also why transmission's taking place. And I think there's nothing that we've identified so far that gives us cause for alarm or concern. But again, we obviously need to try and work hard to get the numbers down. And testing is again a key element of that. And the density of COVID tests, certainly for February, shows that we are seeing a better spread across the town of tests. And again, testing is important because it means we can identify cases, which means we can get people to isolate, which therefore means we can stop the transmission. And again, I think an increase in the opportunity for testing has also, as well as the lockdown effects, been responsible for bringing the numbers down as far as they have come. So I thought just to work through just some current interventions that we are working through the local authority, just to update on what's happening. As I've mentioned there, the testing, a very key element of bringing the numbers down. We have our community testing at the Mill House Leisure Centre at the moment. That started off quite well. I think we've seen a drop-off of numbers of people accessing the testing, so we are going to have to promote that a little bit more. That's the asymptomatic testing, which we tend to try and identify people who don't have symptoms. We're focusing on people who have to go out to work and sending out comms around that to try and encourage people who have to go out to work, because I think workplaces we have identified as one key area of transmission or potential transmission, and so that should hopefully help those people who are unable to work from home to identify if they have if they're asymptomatic but they do have the virus. We're also working with the fire service. We set up a local testing centre for the fire service, and we have our local test sites for symptomatic testing and the mobile testing unit that visits regularly during the week. So we do have quite a number of different options, and that's growing as well, and will grow when you consider we take into account the asymptomatic testing in schools and that which is already going on, or schools from next week, and when pupils go back, but also care homes as well and other areas. We're involved with supporting the contact tracing effort. We have a local enhanced contact tracing system that's been in place, and we now get the calls that the National Contact Tracing Centre can't deal with or can't contact after 24 hours. So we're able to follow those up, and we've had success in reaching those people and informing them and getting them to isolate, which again is, alongside the testing, a key component of reducing transmission. We also, our regulatory services team, continue to do look-back tracing, which involves talking to people who've tested positive and trying to find out where they may have picked up the virus, where transmission may have occurred. That's really helpful to us in terms of understanding the pattern of cases. So we're able to identify, we have been able to identify a number of different outbreaks, which we've been able to support, and in terms of reducing that, as well as understanding a picture of where some of the sort of hotspots are likely to be. Community support is obviously in place through the support hub to support people who have to isolate, and also providing test and trace support payments as well. And we're also developing our community champions program, and I think we're looking to be quite ambitious with this. And I think one of the areas we're trying to look at is to support certainly businesses, public-facing organisations, to have at least one person who can be identified as a community champion, so we can actually really get an awful lot of reach into the community to get that valid information. I think particularly as we move forward with the vaccination programmes, sort of good quality information and advice is key to engaging with people, and I think we have to really focus on that going forward. We are also, as I say, dealing with current outbreak controls. We have an outbreak control plan for Hartlepool, and that actually, going back to some of the points Councillor Thomas was raising about recovery, our outbreak control plan has to be revised in the next 2 weeks. And part of that will be looking at what happens next and including that in the plan and widening it out quite significantly. So we will be picking up those points within the outbreak control plan. What we're currently doing within that is providing support to schools. We have a sort of hotline for schools to call us when we support them when they have cases within the school. We're also providing care home support, and also that workplace and community support for following up with outbreaks. In terms of vaccination support, we've been given the responsibility of supporting that in terms of looking at the inequalities, and we're starting to work this week to bring together a plan to support that as the vaccinations are rolled out. And again, I think that's vital to ensuring that as we move through the age range, that we're able to maximise the uptake as we go forward. And also we've been supporting the provision of venues to support the vaccination rollout. In terms of future work, we're commissioning some behavioural insights work to better understand things like why people may not be isolating, and really to inform the future work as we go forward. It's certainly the recovery effort is key, but also we're going to have to start thinking about how we deal with future outbreaks when we get numbers down quite significantly. And I think we're starting to think about methodologies around once the numbers get down quite significantly, we're going to have some very sort of fast testing and isolating, because we are going to be living with COVID for quite some time, and we are going to have to think about how we can work with our populations to really maximize the way we can reduce transmission quite quickly in very small hyperlocal areas. And we're looking at hyperlocal testing and engagement with communities to do that. And I put there again, as we've already previously discussed, the mental health element is going to be crucial as we go forward, and we're looking to certainly recruit people into a support post within the public health team to do that and drive that forward. But again, it is going to be crucial to our work as we go forward. So that's the presentation, and I'm happy to answer any questions if I can get this screen back. Has that come back on now?
Hasn't just yet for me, but hold on about anybody else. I've got, yeah, all right. I've got Councillor Harrison, Craig.
Thanks, Chair. It's not so much a question, Craig, as an observation, and a bit of intelligence came my way yesterday. Now, you may already be aware of this, but there are some anti-vaccine stickers being put around the town. You do know about it, right? Apparently they're being put on HBC notice boards that usually would be read by visitors, and it's actually blocking some of the important information for visitors. And there's quite a number at the headland, so I'm sure Shane must know about this as well. So it's that kind of thing that you're having to combat as well. It's not just trying to. I mean, I've had my vaccination, so I'm with it all. But at the same time, I can understand people's fears, and if they see something like this, that's only going to make their fears worse. So I think, obviously you'll be doing something about that, but it's I think we all have to try and get the message out that these people are. It's really appalling, I think.
Yeah, it is. I think we have seen some of those previously, I think, and sticking them on various bins, I think, in other areas. And I think certainly people have been out. I think Tony will know better than me to clear them off as well as they've been seen. But you're right, we do need to make sure that certainly the comms and communications, we work really closely with all our partners and the community to get the really positive messages out about vaccinations.
Right. Well, there's one outside St Hilda's Church. And the lady who saw it did actually try to get it off, but she couldn't get the whole thing off. And quite a number around the headland, apparently.
Yeah. Sadly, whoever's been putting them on has quite a big supply of them, because we keep getting rid of them and they keep appearing again. And this is the second time now. Craig will remember a number of months ago we were getting them about masks, so they've obviously moved on from masks, and now they're
the vaccines.
Yeah. But
and I mean, there's an anti-COVID thing as well, isn't it? That some people don't believe there's such a thing. I mean, it's crazy. It's just crazy. And I think within a town like ours, that kind of thing, because we're quite an insular town, that kind of thing spreads quite quickly.
Yeah. Thank you, Dr. Timlin.
Hi, Craig. Just a couple of questions. What's the opening times on the Millhouse rapid test place, and are they using lateral flow or PCR tests?
They are using lateral flow tests, and the opening times, I can't remember off the top of my head. I think there's a variety of different days. We have different opening times, but I can find out and circulate them to you.
It's more for patients. I was just thinking, do you know where where that information's stored? And I could just say, well, look on Hartlepool Now website or something like that.
It's on the council website, but what I'll do is I'll circulate the times, because we have recently.
It's just for patients, because often you get asked,
Yeah. We have recently changed them to maximise the uptake of people who are working. So we've got a couple of later nights each week now as well. So, but I can get those circulated.
Thanks.
Great, thank you, Craig. Councillor Thomas.
Thank you, Chair. And I would just echo some of the comments that have already been made about the stickers that Brenda was referring to. And it is so sad when we see that sort of thing happening after the impact that COVID has had on communities up and down in the country, but particularly the impact that it's had in towns like Hartlepool. And thinking about those statistics that Craig mentioned earlier in his presentation, Hartlepool's death rate from COVID is 25% higher than the national average. And given the health inequalities that we have, contracting COVID in Hartlepool is a more life-threatening thing than the average across the country. And it really does sadden me that we are seeing the sorts of things that you've talked about there, the things that we still see on social media. And it's just really to ask Craig if we are still getting those positive messages out through our own social media about the benefits of vaccine, about the importance of vaccine, and about the importance to maintain the basic things around social distancing that have been priorities all the way through the pandemic. And the second point, Craig, was just around that sort of levelling off of the level in Hartlepool. And you mentioned that being something that's being seen across the Tees Valley as a whole, and some of the social factors that we have within the Tees Valley being a factor that you feel may be influencing that. If you could just expand on that a little bit, and are we seeing any sort of trends in the cases that are currently coming through, any particular age ranges, or any factors that we feel may be leading to that levelling off, other than the social indicators that you mentioned?
Thanks. Yeah, I'll take those points individually one by one. Certainly with the comms, we are putting as much really positive messaging out as we can. We take every opportunity through social media, but also the traditional media as well, to push the positive messages around and to push the messages that we want to get out. And I think we've sort of been commended for the comms that we're putting out, and I think I've put in some exemplary work out there, and always exploring more ways to do that. And I think the comms is a key component of our certainly our outbreak plan and all of our messaging going forward. And I think you're right, it's crucial as we go forward with the vaccines as well, to support the positive messaging within that. In terms of the levelling off, I think interestingly, from when we looked at the Tees Valley-wide data, ours was slightly different. Certainly the Tees were seeing some younger people, certainly children, the 0 to 14 age groups, rising over the last few weeks, whereas ours has remained fairly constant in that age group, and we only saw a small increase. But predominantly, again, it's in the working age population, and that's where we see most of our sort of rises in the cases. Then in terms of whether there's anything consistent, we do look at that quite significantly, but I suspect it's related to the numbers of people we have who have to either go into work or have occupations where they can't work from home. And I'm doing a piece of work at the moment looking at the clusters that we have in workplaces to see if there's any patterns within that. But I think that's why one of the reasons we're offering the asymptomatic testing to people who can't work from home and are having to come into the workplace, because that seems to be one of the areas that we're seeing the most cases. I think at this point it was probably useful to mention as well, one of the areas we're seeing quite a large drop off is in the over 80s, which I think has been a combination of potentially the lockdown, but also starting to see some effect on vaccinations. And that's been quite significant. And also just to clarify, I think you might have put something in the chat. The website, going back to previously about the asymptomatic testing, is on hartlepool.gov.uk community-testing, and that will get you through to the community testing site.
Thanks, Greg.
Thank you. Tony Hanson.
Thank you, Chair. Yeah, it was just to confirm to Councillor Harris and Councillor Thomas that we do remove any offensive material as soon as we're notified of its location. And what I could encourage anybody to do is, if they do happen to find it, if they tell us, and then we would arrange for someone to go out ASAP. So I've noted your location of that one, Councillor Harrison, so I'll get a team across as soon as I can.
Thanks, Tony. Thank you.
Thanks, Tony. And thank you for that update, Craig. Move on to the update from the GP Federation. I've got Fiona Adamson.
Morning again, everyone. I hope you'll forgive my, I'm having a bit of a morning as well, and a bit of pandemic fatigue for, I think, getting the memo wrong. So I've prepared a few small slides, which I will talk to, but I won't show you. Just to give you an overview of what's happening or what's been happening over the past, well, it's pretty much a year, isn't it? I think there are, and just as I speak, my doorbell just rang, isn't that? You couldn't make that up, could you? I'll ignore it, yeah. There are 4 core pieces of work that I think we've been focusing on. One is to design and run new services, often at pace. An example of those would be the COVID care clinics, which are effectively hot services that operate in order to keep the practices free to do their cold work. The second one is a respiratory advice service. When we discovered quite early on in the pandemic that there were a lot of people who've had existing respiratory conditions which weren't COVID, but who were panicking. And so we have a nurse-led service that operates on a daily basis to help those people remotely. And then also I note in the CCG paper, the oximetry at home service, which we used to call the virtual ward. That's something that we've been very proud of as a lead provider. And that's where, I'll hold up my oximeter. So if you can see me, you can see the oximeter. We drop these off with an explanatory pack for patients if they have COVID, to look after themselves, monitored by nurses at home, and to get them into hospital as quickly as possible when their oxygen levels suggest they should. And again, Craig referenced the vaccination clinics. That's something else that we've designed and set up quite quickly. The other theme is making sure that what we do already is fit for purpose. So the urgent care service, our Footsteps mental health service, our ordinary access to GP and nurses overnight became remote services. And with the ability to see people face to face as and when it was clinically required. Our social prescribing was a particular success story, but again, it's a service that we've generally run remotely. And the social prescribers have supported literally thousands of people in the community, working alongside the council teams to try and get people the services they need, and just to make sure that those people who are isolated are actually okay and have a friendly voice. The third theme is pausing and reintroducing some of the services that we already had. So our 7-day access service is a good example. At one point, all of our services were COVID specific. And then we worked with Karen and her team to look at what do local people need and reintroduce some of the cold services, for want of a better phrase. And we review that on a monthly basis together. And then underpinning all of that is trying to continue to support the primary care networks, who were really just formed, got up and running, and then was thrust into the middle of a pandemic. One of the exercises that we did in the summer with our team, which was really helpful, was what we called an innovation analysis of our pandemic response. And that was really to take a step back and have a look at what things did we start doing in relation to the pandemic that we should review or stop? What did we start doing that actually is great and we should keep it ongoing? What did we used to do, we stopped doing, but actually it wasn't fit for purpose and we shouldn't pick it up again? And what things did we stop doing, but actually we needed to restart? And that was a really helpful exercise for the team to decide how we go forward. So what has gone well? I would say relationships, that's absolutely top of my list. I mentioned that earlier, but I think some great examples, the oximetry at home service with the CCG and other local federations, but particularly the vaccination clinics, where Craig's team and Jill's team have been absolutely brilliant in getting the town halls set up, where we have a really safe, efficient model. I think agility and expertise, so we've done things quickly, but we've really had to learn very quickly as well, and that's been something I've been quite proud of the team have done. Team welfare, it's finding different ways to keep people going, particularly when they're working remotely. And technology has played into that. So even our phone system was transformed overnight. So one of our team might be sitting in their bedroom, but actually the person talking to them wouldn't know it. And then finding new ways to communicate, which I think we've all had to do. So I never knew how many WhatsApp groups I needed in my life until the pandemic started, but there have been lots of different ways. Lunchtime drop-in sessions on Teams or Zoom for GPs, all sorts of things like that. And then clearly we saw some challenges, and a lot of challenges. Keeping the team going was one that I've referenced. I think the clinical response and the education. So I take my hats off to our GPs and nurses who were faced with something really new and had to get to grips with it, and had to get to grips with changing treatment strategies and learning all about a new illness. It is difficult to keep communicating and keep your communication fresh. I think when you start thinking about local people, that becomes even more difficult. And we've been conscious throughout this of some of the health inequalities and particularly things like digital exclusion. And that's something that I've got the social prescribers looking at quite closely. I think, and then underpinning all of this, there were some big strategic changes which we have on our agenda today. So looking at where does the federation sit, what is our place in the world, and I think the place, and talking to the integrated care system, place is a good word for a federation, because we are bigger than PCNs who can really focus on their neighbourhoods and their communities. We can sometimes do things once, as I think we've shown during the pandemic. We can do them once or twice when actually they would have to be done 7 or 10 or 20 or 30 times if it was at individual practice or PCN level. So that's a very whistle-stop tour of a very challenging year, but which has nonetheless brought some positives as well. Thank you very much.
Great, thank you very much, Fiona. We've got Dr. Timlin.
Yeah, I'd just like to thank Fiona and Hash for extremely good support through this year. That certainly when they set up the COVID clinics at the beginning, there was a lot of fear in the general practitioner population about patients coming down and infecting them and people being off. And with this quick setup of the clinics, it took all the pressure off. We were able to refer patients in, you know, even if we were unsure they had COVID or not, they would get checked over, and when the tests came out, they would get tested. The virtual ward was like a pilot which has been sent out across the country, and Hash again was fast to take that on board and move it forward and sort of like spread it across the Tees Valley. And the respiratory advice service similarly, that's we moved across the Tees Valley. So I think Fiona's done a great job with all the sort of stuff that's been going on.
Thank you, Nick. That's really appreciated. Yeah.
Thank you. And I've got Councillor Thomas.
Thank you, Chair. Fiona, excellent presentation, and clearly an awful lot happening during the COVID period. And I think one of the things that you touched on was social isolation. And certainly COVID has really highlighted social isolation, both from the perspective of the impact that it's had on people during COVID, but I think it's also cast a very sharp light on the degree of existing social isolation that was out there in our communities. And I know that the social prescribers have been playing a very important role in connecting people to organisations and services, whether they be with statutory bodies or within the community and voluntary sector. And I think one of the positives that has come out of COVID has the degree of collaborative working between different health partners, the local authority, the community and voluntary sector. And I think that that really needs to be built on and taken forward if we are going to successfully start to address some of those issues around social isolation. And clearly there's a lot of people out there who really haven't hardly set foot outside their doors probably for almost 12 months now. And a lot of those people are going to need support as the lockdown starts to ease and as we start to head towards a more normal sort of living environment. And it's just sort of like to get some thoughts as to whether or not you've been thinking about taking some of those issues forward and planning for providing that sort of support as we move into the next phase of the pandemic.
Yes, thank you. I think you're absolutely spot on. And even from a personal point of view, having been working from home for a few months, the first day I had to drive into the office and set foot in a team environment, I actually felt quite nervous and just quite unsettled. So I can just imagine how people have been in the house on their own, how they must feel the first time they go to the shop or whatever. The social prescribers are really keen to get out and about again, to think of some innovative ways. We've got some ideas for groups going on. We want to do something that's known as green social prescribing. We'd like, we're working with Hartlepool on some ideas around that. I think it's going to be a question of working with the primary care networks to decide the priorities and what the patient groups look like for each one of those networks. There's a strong tie into to Deepak's team and the new long COVID service to make sure we get the right people into that sort of fairly specialist service, but actually that we don't let the other people slip through the gaps. There'll be some people who perhaps don't have the degree of problem with long COVID that would warrant an extra intervention, but actually they're still poorly. So we've got to focus on that, and I'd quite like to get some people dedicated to supporting the long COVID effort. So definitely, and I wonder if perhaps it might be appropriate at some point to circulate a short paper around the board members just to let you know what we're doing with that.
That would be great. Thank you, Fiona.
Thank you.
Councillor Ward.
Hi there. I'm just listening there and just following on from what Stephen Thomas said as well. I've been running a support group throughout the pandemic, and the anxiety, it is well noted. Now, for those that have been able to attend the support group, I mean, that's brilliant to be able to get out, but reaching out to those that I talk to online and support, there is that absolute fear now. I think it's because they've been shielding for so long, or they've been in the home so long. And I think, the social aspect of the anxiety around mental health is absolutely massive. And I think it's definitely working together with community groups like ourselves and different things to go forward and bring the community together and help them with the mental health and anxiety that has raised even issues where you wouldn't have normally had it before, but it's a brand new thing for them. So, some people that have never suffered from anxiety before are now actually, suffering from anxiety. And that's what I see, with the work I do every day, and obviously in the support groups as well. So, that it's brilliant if, the community all coming together and working collaboratively. I think that's definitely the way forward.
Thank you. And Jill Harrison.
Thank you, Chair. It was just picking up on the recent points made around social isolation, and particularly those people who've been shielding. Obviously, through the support hub, we've been supporting those people over the last year who've been shielding, and just recently had more people added to that list. So the positive is that we do have contact details for all of those people. We're proactively in contact with them on a very regular basis. And certainly when previous lockdown measures were eased, we did support those people to look at how they could start getting out and about again after such a long time being shielded. So obviously that will continue going forward. And I just wanted to reassure members of the Health and Wellbeing Board that the support hub model will continue. It's not something that will stop when shielding stops or when lockdown measures are eased. We plan to continue with that way of working going forward. And we've certainly found through the digital offer and being able to help people stay in touch remotely, they've really valued that. I appreciate it obviously doesn't replace face-to-face contact, but we do have some very active older people now who are sort of setting up their own WhatsApp groups and Zoom bingo sessions and taking part in online exercise and a whole range of different things. Reading groups, being able to still access library provision online. So there are some real positives from that that we'll build on going forward. So just wanted to remind people that model will still be there. And obviously we do work closely with the social prescribers and other partners around that. So we'll continue to do that as the lockdown measures ease.
Thank you, Jill. And Councillor Harrison.
Yeah, it must be the name, Jill, because I was going to mention something very similar, because when this all first happened, I think there was a lot of support put into people that hadn't had it before. So in fact, some people who suffered from social isolation before COVID actually were helped by the situation, if you like. And I'm really glad to hear, because that was my question really going forward, but I'm really glad to hear that the Support Hub, which has done a fantastic job, and I know that because I've been in contact with some of the people who've benefited from it, and you know, I'm glad to hear that it's going to continue and that it just won't stop, because I don't think anything can just stop, because I don't actually think COVID will stop just like that. Thank you very much.
Okay, thank you everybody, and thank you again, Fiona, for that presentation. Much appreciated. We now have Karen Hawkins from CCG.
Thank you, Chair. For members, there was a paper that was provided. I don't intend to go through the paper in detail, but what I will do is I'll provide you some of the key areas in relation to the CCG's response to the pandemic and where we are as of today. So obviously we are a year forward. It feels like this year's just disappeared in reality. And to make sure that we were able to respond to the phases of the pandemic, a number of actions from a CCG perspective had to be undertaken. We obviously had our own business to ensure that we had our own business continuity plans and things refreshed, and also that we put some system leadership in place 7 days a week to make sure that people were able to contact us. So we undertook that in terms of our business. But what we've done, which was really important, we are a clinical commissioning group and we have a number of clinicians that work with us as a CCG. And we had to free up all of our clinicians to return to general practice to ensure that they were able to focus and continue to build on the pandemic response and deliver the clinical services that were needed at that time, and that continues. We also, and I think one of the things learning from the pandemic, obviously as an organisation, every organisation has their own governance arrangements in place, and some of those can be quite lengthy in terms of timescales and turnaround. So we changed our governance arrangements to make sure that we were able to make urgent decisions in response to the pandemic, so that action could be taken by our clinicians and by our practices, as our key focus was particularly within primary care. Dave Gallagher, he was our new, as the pandemic hit, he became our new Chief Officer for the Tees Valley CCG. And Dave put in place some arrangements from an ICP, so the Integrated Care Partnership. So that's bringing all organisations together to make sure that we had a group that met during the week to look at how we managed the system at that time, any areas or any barriers to be able to progress, and where additional support might have been required. That was put in place early on in the pandemic, and that continues to be in place. But we'll take a different focus as we move forward, more around recovery at an ICP perspective, but also being really mindful that at locality perspective, the Health and Wellbeing Boards will set the agenda as we move forward as well. But we absolutely need to focus on recovery as a system as we move forward. In terms of primary care, we as a CCG are delegated responsibility from NHS England and NHS Improvement to manage GP practices. Obviously, the government set some very clear direction for practices in the way that they had to work. So practices in the way that they'd worked for a number of years changed, and that they had to move to remote triage to make sure that only patients who were clinically necessary to be seen face-to-face were seen. And that was not only to protect patients at risk of COVID, but also to protect our workforce. Fiona's already alluded to a number of services that we commissioned to make sure we were able to respond to the pandemic. And we worked with Fiona and her team, particularly in Hartlepool and Stockton, to make sure the services that we currently commissioned from them changed, and we put in place what Fiona referred to as the hot clinics, to make sure that anybody that was suspected of being COVID positive at that time could be seen in a designated site, and there was one in each locality to make sure that general practice were then able to continue manage those patients face-to-face who were non-COVID and required a clinical consultation. And that, again, was in response to ensure that we were able to support the public, because there was a lot of fear at that time. Now that continues, so those clinics continue, although we have adapted them to make sure that they're able to see both hot and cold activity now. And then I won't go into the detail because Fiona's already covered it around the respiratory advice service and the COVID oximetry at home that we've worked with the Federation in relation to, and that they've been fantastic in terms of that response to COVID. The way primary care works has changed and will change now. Obviously, we supported the digital rollout into primary care to make sure that patients could be seen remotely, and whilst they weren't able to access general practice initially. And that has continued, and that's really grown over the last year in terms of the way that patients now expect to be treated and seen within primary care, but not removing that need for face-to-face contact. So that is still in place. Patients are still able to access face-to-face consultation where that's clinically necessary, and obviously in adherence with the guidelines around the social distancing. We've worked with partners in the management and support of care homes, including specialist advice, the enhanced health and care home model that was rolled out through the multidisciplinary team, and training and education of the care homes through the initial phases of the pandemic. But that has also continued now as we roll into phase 3 of the pandemic. The collaborative working and the partnership support from all agencies across our area has been phenomenal in terms of supporting that approach. We have worked across in the early stages around the supply and the distribution and the management of PPE, and then we've also made sure that we're able to work through the integrated care partnership group to look at what will in essence be the new normal as we return. Now we have supported importantly and coordinated the vaccination programme since the beginning of November. We have 3 primary care networks in Hartlepool, and primary care networks are groups of practices working together. We've got 3 designated sites across Hartlepool, and there was a requirement nationally to designate a site to be able to deliver the vaccination programme, and that was to make sure that we were able to coordinate the deliveries of vaccinations and also the management and the handling of the type of vaccines that were being received. So the practices working together through the primary care networks are delivering the vaccination programme and from the sites, but also the vaccine changed in January. We got a new vaccine, which was AstraZeneca in January, so they were able to utilise that vaccination to do housebound and home visits as well. So I think one of the things from a systems perspective, and certainly from a practice perspective, we can't underestimate the work and the fantastic work that's been undertaken by the practices, by the primary care networks and by partners in response to the pandemic, and particularly in response to a rollout of a whole new vaccination programme that's never been seen before. And Hartlepool commenced the vaccination programme in December. The 3 PCNs all came on in December through the designated sites, so we're able to start the programme. And as of early last week and this week, we're seeing second vaccines now being delivered in line with the guidance in Hartlepool. So that's a great step forward. One of the things that we've supported and that we'll continue to support working with partners is key communications, and some of the things that have been brought up today around that myth busting and making sure that there's fact sheets available so that patients and people are getting the right messages in relation to COVID and in relation to the vaccination programme. You'll have seen some fantastic media that's been out there in relation to our clinicians and clinicians in the trust advising around the programme and myth busting in essence to try and ensure that the public are aware of the fact in relation to the programme. One of the things also that we're doing is we're working across the outbreak management groups that are led by our local authorities. We're a key partner within that, and we make sure that we work with our directors of public health, because the next areas that we'll be looking at in terms of recovery, it's really important that has a locality focus. So in terms of where we are now and our next steps, so through the Integrated Care Partnership Group, we are focusing on recovery. We're looking at the next steps across both health and social care, being mindful that work undertaken at a locality level, but also ensuring a coordinated approach. We will continue to respond. I think Councillor Harrison's already, COVID isn't going anywhere, it's still here. We will continue to respond to the COVID pandemic, but also the demand that that brings. We will continue to focus, announced nationally. Obviously, the Joint Committee of Vaccination and Immunisation has announced the cohorts that need to be vaccinated, and they announce at what point each cohort requires their vaccination. So we will continue to work with our PCNs, with our practices as we move forward. We will be maximising the capacity in all of our settings, whether in any provider setting, to make sure that we can learn from the good work that's happened during the pandemic and that we don't lose some sight of that. We will respond, as Craig outlined earlier, to outbreaks in particular areas and also the ongoing pressures that might realise. And we will continue to support the health and wellbeing of the workforce. And I think it's really important to make sure that there is a focus on our workforce. People have been working at pace over the last year and continue to work at pace. And we need to make sure that our workforce is sustainable as we move forward. Because obviously this is a pandemic that we're working within at the minute, but we also are continuing to deliver routine care, and how we support our workforce is really important. And that's something that we will do collaboratively across our areas. I think, in terms of where we are now, the joint working that's happened and the benefits we've realised from that over the last year around all of the responses and all of the actions that have been taken in partnership can't be underestimated. And I think in the last year, the relationships, the technology, the responses and the working together, although the pandemic has been really difficult to deal with, has put us in a really good position as we're able to move forward. So that's all I intended to cover, because there's lots of information you'll see in the paper, but if there's any questions, I'm happy to take those. Thank you, Chair.
Thank you, Karen. Thanks very much. There's some great information in there. There was just two points from me, if I could. The first one was just to give my thanks to everybody who was involved in the vaccination rollout. I know not everybody will have been aware how successful it was in Hartlepool really early on, and the massive uptake we had. And I know, speaking to other leaders from certainly around the Tees Valley and further afield, they were in absolute awe at the speed at which it was started to be rolled out here and the uptake from the public. So obviously that isn't something I can take credit for. It's all on you guys. So I just wanted to extend that thanks and say how really appreciated it was. And the second one is just coming back to routine care. Karen, how have you been finding things in relation to carrying on the day-to-day business and getting people to still come forward for those other issues? Are you still managing to keep on top of it, or are you finding it a bit of an uphill struggle in trying to get people to keep up with them?
I think in terms of phase one of the pandemic at the beginning, obviously with the national lockdown at that time, it was really difficult to continue the routine care. Routine care was still provided, but provided predominantly remotely, because that's the instruction from an NHS England perspective that was given to GPs. GPs continue to do that, but since July and the second phase of the pandemic, all services were asked to step back up. The majority of the services that hadn't happened in phase one. The additional activity that we commissioned through our improved access service, so where Fiona had alluded to earlier around, we had in phase one, we had all of our additional access we had it predominantly dealing with COVID and with COVID suspected patients. In phase two, we stepped some of that down and stepped back up the additional activity we had from GP practices and from our improved access services to see more routine patients, and that they were able to be seen. Obviously, in terms of the patients, they still, it's where it's clinically necessary they're seen face to face. I think as we've all alluded to this morning, COVID hasn't gone anywhere. The vaccination, although the vaccination program's in place, we still have to ensure adherence to the social distancing measures, our hand washing, And we're making sure that patients who require face-to-face contact are seen, and that's delivered from all practices across the patch, including our improved access services. So that has stepped back up. We look at the levels of activity, and we are back to where we were pre-COVID and beyond, because of the online access that's now available from practices. And this is where I was saying we need to make sure our workforce is supported, because they are delivering the programme on top of what they were already delivering for routine care. That has been made a bit easier through the designated and for vaccinations. But as we see the care home programme starting, that has put additional pressure where they weren't delivering that in the past. But patients are accessing services as they did pre-COVID now.
That's great, thank you. Councillor Thomas as well.
Thank you, Chair, and thank you for that report, Karen. It was, I think, very, very informative of much of the activity that's been going on during COVID. And I would echo the Chair's comments with regard to thanks to the staff who have been involved in the vaccine rollout, and sort of extend that to everyone from health, social care, community and voluntary sector, who really have worked so hard during COVID. And I think without the dedication of whom, a very awful situation would have been far worse. So please, if you can pass the thanks back from elected members to your staff and to other colleagues in the health sector who've been involved. The question I was going to have for you, though, was, I think rightly within your presentation, you talked about some of the joint working, some of the collaboration that's been happening through COVID, and some of the really excellent results that have stemmed from that. And I was just wondering if moving forward you will be looking for opportunities in commissioning processes to be able to further embed some of that good work that was happening pre-COVID, being developed further during COVID, and taking that forward, because I think the positive outcomes for health providers, patients, care service users from such approaches, I think are without doubt. And I think it's one of the few positives that has come out of COVID has been that reinforcement of those benefits from come when different providers are working together in the interests of patients and service users.
Thank you, Councillor Thomas. I will pass on your thanks. And to be fair, your officers throughout the whole process have ensured that our primary care colleagues and wider partners have been thanked for the work that they've undertaken to date. I think in terms of joint working and collaboration, what I wouldn't like is there a perception to be that wasn't happening in Hartlepool. It absolutely was. From a local authority perspective, and the work that we've done with your officers over the last number of years has been really collaborative. And I think absolutely we need to continue that work and work in collaboration. No one organisation can do this on their own. And I think the collaboration in the joint partnership working has been strengthened because it was always there in Hartlepool. And the way that we all work together across organisations, but there's loads of opportunities, I think, as we move forward as to how we strengthen that and continue to strengthen that, especially through the recovery process and how we look at recovery and some of the suggestions earlier around that joint working that you put forward, Councillor Thomas, around recovery. It will be fundamental as we move forward, and no one organisation can do that standing on their own. So that will continue. Thank you.
Yeah, Chair, I do have the impression that it wasn't happening previously, because certainly in Hartlepool there has been a very, very strong and positive record for a long time of services working together. I think the point I was trying to make was that really has been emphasised, I think taken to another level by COVID. I just hope that continues, as Karen has said.
You're on mute, Shane.
And I'd done so well up until that point, Brenda. I'm told Councillor Buchan...
Can you see? Oh, yeah. I just wondered if you could see that.
No, I can't, but yeah, I have been notified. So, Bob, have you got a question?
Thank you, Chair. I'll just echo what Councillor Thomas said. He saved me saying it. But there was another point. And what it is basically, I will be having the injection of vaccine this weekend. Will I get a card to prove that I've actually had it?
Yes, you will, Councillor Back, and you'll get a little passport, a little COVID passport that has your details in the batch of the vaccine that you've been provided and the date that you were provided it.
That's brilliant, because say you wanted to go on holiday and you were asked, have you had the vaccine? You can just show that. That's why I asked. Thank you.
Great. Thank you very much. Are there any other... Bob, Councillor Ward?
Yeah, just quickly, I picked up there. It's just obviously with the feedback I've had and with the anxieties around people, some of the anxieties that do come back is those that are genuinely have anxiety over the vaccine. Yeah, there's a scaremongering that's going on. You can see, the leaflets which we have had on our ward, people have had posted. But it's just maybe it's to be a bit mindful. I don't know how things are going to go forward for those that maybe they've got chronic illness, they've got autoimmune condition. I put my hand up to that with an autoimmune condition, and those are that little bit worried about having those injections. So it's just to be a bit mindful going forward that there is people. It's not so much that they don't want it or that anti-vaxxers are actually very, very concerned because of medical conditions that they do have, and they've got those worries. So there is those embedded worries that's causing anxiety with a number of people. So just to highlight that as well for those.
Thank you, Councillor Ward. It's obviously not just those with medical conditions as well, because I mean, I might be 6'4", bit of a burly northern bloke and rough around the edges, but when it comes to needles, I'm terrified as well. But I will obviously be doing my duty.
Can't feel a thing, Shane. You're all right.
Can I come back on that, Sean?
Yeah.
It's just that, I mean, every time somebody comes through, they do see like a doctor who consents them and they can discuss anything there and then, and if there was some sort of problem, it will be identified, and, occasionally people have been blocked because it was inappropriate, but they're very, very safe vaccinations, so there's hardly anybody who shouldn't be getting one.
Brilliant, thank you. And Fiona?
It's just to build on Nick's point, really, to say that A, they're very safe, but B, that there's some really good work going on in a couple of pockets nationally where for those people who are nervous or who've refused their vaccine, they're looking at GP-led services where a GP will actually call those people. And I think it's quite an interesting approach because people trust a GP, people know that they're experts, that they've got their best interests at heart. And some of the early results from people being contacted by a GP who previously refused a vaccine, they're looking at somewhere between 70 and 90% of people then agree to go and have it. So it might be something, I know Craig mentioned earlier, the work around health inequalities and vaccination might be something that we want to consider locally.
That's a great idea. Thank you, Fiona. Before I move on then, is there anybody else with a hand up that I don't see? No. Great. Thank you very much. And then the final update then is from Deepak at the Foundation Trust.
Thanks, Shane. And hopefully all of you will have a chance to quickly browse through the paper that we've submitted, really. Really to echo the previous three speakers, the great things of COVID, and there have been many positive things out of this terrible, terrible illness, has been the teamwork and collaboration, incredible amount of hard work I've seen from everyone from, within our staff, from the porters to domestics to, consultants, senior nurses. Everyone has really pulled together, and it's been an awesome team event, and it's been great. It's been a pleasure to lead them through parts of this. I think the big challenge for the clinical teams was probably for the first time in virtually everyone's career. This is a disease that no one knew really anything about, and particularly in wave one, it was supportive. We were supporting people in various ways with rudimentary treatments, like just giving them oxygen, giving them fluids, plus or minus respiratory support. And the only way that things have improved going into the second half of wave one and into wave 2 and 3 has been really research and innovation, and I'm proud to say that the Trust has been one of the leading contributors in the country to the recovery trial, which has been the biggest international study on the treatment options for COVID. We are in the first 1 or 2 trusts for the numbers of patients we've actually recruited into the trial, and one of our clinicians has actually been co-opted into the organising group based in Oxford. So that has been one of many successes through it. It has, as with all organisations, put us under immense pressure, and we're still under a degree of that pressure. So the peak of wave 1 was 76 inpatients and about 24, 25 ITU patients. During the peak of wave 2 in January, we hit 216 inpatients with COVID. I just checked the figures just now. We still have 58 inpatients with COVID, and we still have, I think, about 8 or 9 patients on intensive care with COVID. Everyone thinks it's just a disease of the elderly, and I want to get rid of that myth. We've had young people who have come in desperately. Our youngest patient ventilated, who I'm pleased to say had survived on ITU, was 28. Okay, we've had 2 pregnant women who have had to be ventilated and treated on intensive care. So it is really important that everyone understands this disease. Yes, it does pick on older people, it does pick on frailer people with comorbidities, but it can make young people extremely ill. And I think the important point, before I go into some more detail, is that the only way we will control COVID and come back to a degree of normality will be everyone taking their social responsibility and personal responsibility to get vaccinated. And we need to get rid of the anti-vaxxers. We need to ensure that any fear is calmed and that people are educated. And there's a lot of stuff that we've already put out with regard to vaccine hesitant people, worry about vaccine in pregnancy, and other issues with regard to the vaccine. So that's my sort of plugging at the beginning of this little talk. So really concentrating initially on ITU, and I will preface this comment by the fact we've run COVID through an ancient building. This building at North Tees was designed in the early 60s and completed, I think, around about 1967. So it's 50 odd years old. It's well past its sell-by as a structure. It's not built for modern infection control practices. We barely have 17% of our beds that are single rooms, so it creates a big issue with regard to separation and stuff. And the pipework and stuff was a massive challenge with regard to oxygen delivery. So our intensive care unit is a modest-sized unit, and it's topical because it's in the national news today, and has 16 commissioned beds. At one stage, we were working at 162% of that capacity. So we've gone through all of the ITU beds, we've gone into theatre recovery, and we were ventilating and treating patients safely in the theatre capacity. So this was a huge challenge for us, really. And just looking at sort of the some of the admission numbers, we were running between 3 and 35 patients being admitted per day into the COVID wards. And that's the equivalent. 35 is more than one ward's full of patients. As I said, we got up to 216 patients with COVID, which is, give or take a few, 42%, just under 50% of our total bed capacity at one stage was COVID. As you can see, there's a graph 1, which shows the sort of the flow of patients into the building. At one stage, 40% of the patients required some form of oxygen therapy, and you'll have heard a lot about this on the news with what's called non-invasive ventilation, basically tight masks blowing oxygen into people. That puts a huge pressure on the oxygen infrastructure, and our estates and facilities department were way ahead of the game in March when they realised the oxygen capacity of this building here at North Tees was nowhere near enough. We had to move the VIE, which is a big thing that stores oxygen, from Hartlepool over to here over a long weekend with the collaboration of BOC, and that helped. During this, when we had a bit of a drop during the summer, we doubled the oxygen infrastructure at the North Tees site. But even with all of those changes, at times during January, we've really almost come to the buffers with regard to oxygen, and we've had to manage patients and where you put them in the building very, very carefully. As you can see in graph 2, you can see the age profile of admissions. They are higher in the over 70s, and you can see the impact over the weeks there. The other obviously important factor is COVID didn't just affect patients. Some of our staff unfortunately also got COVID, and during the peak, if I remember the figures correctly, we were at a minimum had 20 patients off. At one stage, as you can see in graphic 3, we had 633 members of staff off, and that was huge. We still have, I think, around about 100 staff off with COVID, shielding, etc., etc. So this put an enormous amount of stress. I think we were running around about 15% absence due to COVID and normal levels of sickness and staff vacancies. So this really made the management of the clinical areas almost a shift by shift sort of management issue. During the whole of the management of COVID during the last 12 months, governance and the way we organise ourselves has been a priority, and we had a certain number of clinical groups that were really embedded. We've actually almost come to the anniversary of them 12 months ago, and this was the clinical advisory group that was chaired by myself. Resilience and recovery was really from the start. We started to think about that. We had a workforce group, comms, and also procurement group, and this all fed into a strategic command group, which then went obviously up to the executive and board as required. And you know, sometimes these groups during the height of the pandemic were meeting on a daily and occasionally twice daily basis. Really, we liaised, as we've all said, with local partners, and that close working relationship, the facilitative way that people work together was tremendous. And obviously we had input into regional as well as national groups across the ICP and ICS and through the various resilience forum. As with, I think, just about every service in the country, we've redesigned pathways, innovated and taken steps forward, which I think again will be some of the benefits from COVID. The big difference between wave 1 and wave 2, 3 was during wave 1, basically the message from central government was shut everything down. So we just became a COVID hospital. So people were fearful of coming in. They didn't come. Outpatients was restricted just to 2-week rule, query cancer and urgent referrals. Routine operations stopped. Everything stopped. So all of our physical and mental efforts were just managing COVID, whereas with wave 2 and 3, the message was totally the opposite. Crack on with all the normal things we do, as well as manage COVID. So we were still doing routine clinics, procedures, diagnostics, seeing normal stuff coming through the door, as well as dealing with increasing numbers of COVID. Obviously, as we went into the latter half of December and into January, there's no choice but then to really hone down to the urgent work, emergency work, and COVID. Obviously, everything else was parked. There's a huge list of work and things that we've done and collaboration that we've done, and I won't go through it all. As Karen and everyone else has said, and Fiona have said, there's a there's a massive amount of work to be done with regard to recovery. There are people who have obviously had their operations postponed and delayed that we need to catch up on. There's normal outpatients, normal reviews. So there's a lot of work to be done, and this will take us through probably until sometime into the autumn to really catch up. There's also our system responsibility across the ICP to support other trusts who have got worse problems than ourselves. And obviously we fit into the workings of the ICS across the whole of the North East. So to summarise, really, it has, without doubt, and each one of us would say the same, being the biggest professional stress any of us ever worked with. There's been an enormous amount of effort and collaboration, innovation to actually ensure that our patients have had the best possible outcome. Sadly, we've obviously seen a lot of people die from this disease. It is an awful condition. And again, going back to some of the comments towards the start, and I resisted putting my halfpenny in, the people that say that COVID doesn't exist, I'm more than welcome to talk to them and give them a tour of the hospital. The anti-vaxxers are doing people really severe harm and must be stopped. And those people who have so-called vaccine hesitancy, that goes to the BAME groups, people with needle phobias, Shane, and obviously some women, I understand, who are in their fertile years, are worried about fertility and stuff. All of those things we've got evidence for, and we've already putting out comms to try and reassure people. So I'll pause there and take any questions.
That's great. Thank you very much, Deepak. Firstly, although I might be scared of them, I will be going out and getting my vaccine. That's not an issue. I just highlighting the point that I do actually, not brave when it comes to needles, unfortunately. But just put on record my thanks to everybody over at the Trust, Deepak. We all know what an amazing job you've been doing under extremely difficult circumstances. But I just wanted to repeat my thanks from previous meetings. It really is appreciated. I've got Councillor Harrison.
Thanks, Chair. Yeah, just to echo what Shane said, I think that everybody appreciates what the NHS are doing at the moment. And I think that things might have been made a little better. You did actually touch on the fact that, the hospital is past its sell-by date. And if certain decisions hadn't been made in the past, then perhaps we will be in a slightly better position to help, because we have two hospitals between us. And if they were working to full capacity, we might have found, I know Hartlepool has helped out, but if we'd had two working hospitals or a replacement, which it was into the 21st century, and I know nobody here has made those decisions. I'm not getting at anybody here, but I think decisions in the past, there hasn't been any foresight, let's put it that way. Nobody expected COVID, but surely people in certain positions in life need to plan for the worst thing happening. And, the worst thing has happened. And in many cases, we haven't been prepared for it. And unfortunately, it's the likes of yourself, Deepak, who are actually suffering because of it, who have to work in a situation which is, well, as you said, the worst situation that you've had. There could have perhaps been a better outlook had there been a better forethought. But there you go, it's all done.
Thank you, Councillor Harrison. I've got Councillor Thomas as well.
Thank you, Chair. And again, Deepak, echoing the thanks from the other elected members. And just a couple of quick points. You mentioned about naturally a lot of sort of elective planned surgery, other types of surgery have had to be postponed due to the massive pressures that you've had from COVID. And I've heard quite a few different timescales being mentioned in the press and locally about how long that it may take to get some of those, to catch up with some of those different types of surgery. And I was just wondering what the position at North Tees is around elective planned and other surgery, and how far into the future you feel it may be before those people are caught up with. The second thing was around long COVID, and I suppose it's still very much a developing area with regard to the knowledge that we have around long COVID and the impact that it will have in the longer term on people's lives. And I was just wondering how many cases have come through at North Tees and the sorts of symptoms and longer term implications for health which are sitting with those patients at the moment. And the third one, I think, links very, very closely into both of those issues. And you've mentioned in your presentation around the pressure that staff have been under. And over the last 12 months, some staff must be getting really, really close to burnout now. And you've mentioned some of the pressures of staff sickness and absence. And I was wondering, what is the hospital doing at the moment around providing support to staff within the hospital and assisting staff in what is an absolutely, must seem like a never-ending time of high pressure, and thinking about the pressures that are going to come after COVID as well. It isn't something, as we've said, COVID isn't just going to go away, and the normal day-to-day health pressures are still going to be there as well. So I think that there is a lot of pressure on staff, and just thinking about the support that they can be provided with going forward.
Thanks, Councillor Thomas. Three very, really pertinent questions, and I'll answer them in reverse. So we go to staff pressures, resilience, and the ability to cope. Really, as you quite rightly said, and I've said, most pressured time in anyone's career. Huge numbers of patients to deal with. Sadly, we saw patients die very quickly when they come in with COVID, and this was in lots of parts of the hospital. So we've made changes really from March onwards, as soon as we saw this happening. So one of the things we moved to, which has been both support to the patients and also to our staff, is we've got the palliative care team working 7 days a week, basically, which most trusts have never had. So that's supported both families, patients, and also the staff. So that's giving psychological support for the staff. We have a psychology team within the trust who have done in-reach work into the ward areas, particularly that felt the stress and strain, particularly. We also, as an area to have a breakout and get away from the heat and the intensity of the wards, for about a month, I think it was in April now, we had a tour bus. We rented out, so when Elton John goes on his tour of the country, he has a very flash double-decker bus that he sits in with nice areas to sit in, comfortable bits, sneaky snacks and all the rest of it. So we actually had that as a rest area for staff to go to, which was greatly appreciated. With the money that Captain Tom, changed into a relative, Captain Tom put into the NHS charities. We bid for some of that money, and I think we got somewhere around about 70,000. And round the back of the hospital, where the old creche used to be, that's been changed into what's called the Rainbow Room, and it's a quiet area with seating. I think it's got a small gym in there, area for people to do a bit of Pilates, a quiet room for people with autism. We've got as the weather improves, we've got an outside area as well. We're going to put some seats and all that sort of stuff. So that's there. We've got CHUV through their work have linked in with the chief exec, and we've got people, councillors and stuff who are helping to support the staff. So enormous amount of work has gone in there. We've also had to obviously deal with patients who have serious illnesses themselves and have been worried about shielding and have been working off site. So they've had electronic communications to do all of that with. So totally right. You know, the building is, the building's the building. The staff are the people that do the stuff and look after people. And as you're quite rightly saying, if we don't look after them, you know, they can't look after the patients, sort of thing. So it has been a really high priority together. Unfortunately, I think there will be some staff who will be burnt out by this, and we will actually out the minimum number. I think it will also attract a lot of staff into the NHS. You know, to see, you know, people will realise what the NHS has been doing, what the organisation as a whole can offer as careers, and we're doing a lot of work to actually explain to people the NHS isn't just about doctors, nurses and porters and stuff. We must have 100 different professions and career options in here. So that's very important. Then long COVID, right? Long COVID is going to become a significant issue. We've set up a long COVID service through one of the respiratory team, looking at that, and there's a program of imaging, X-rays, CT scans, so-called pulmonary rehabilitation to get people up and running. And I think this will pick up all of the problems with COVID. And I think there will be a rump of people, sadly, that will have symptoms for some time, and time will tell us what they will be and how we will need to respond as an organisation, both with primary care and obviously with the CCG, to see what is required. I can't tell you how many people have been through the service, but I know it's been running for a month or two already. And then with regard to your first question, the last I'm answering, is the elective work. Yeah, incredible amount. You know, there have been a lot of people who have had their operations and things postponed. As I said, we have kept all emergency surgery going. We've kept virtually all cancer surgery. A handful of cases had to be delayed in the height of January. So we kept all of that. There's been cooperation across the ICP and the ICS with regard to using resources appropriately. Our number of so-called 52-week waiters is a few hundred, which when you look at other organisations across the North East, it's a very, very small number. I'm being conservative. I think we will probably catch up by sometime in the autumn. We've got to remember that the anaesthetists who are going to put people to sleep to have their operations are the ones that have been manning the intensive care and all the extra facilities we've put on. So we're keen that they all, literally, and the theatre staff, etc., have all been manning that area. They all need a bit of a break, so we're really pushing people to take. I know there's not a lot to do, but at least to sit at home and, you know, relax. So before that, we start saying to them, right, we want you to work harder, do more, and do weekend working and all the rest of it. So there is a balance there. We want to catch up as quickly as possible, but we've got to sort of protect the staff. And sort of pessimistically, there will be a wave again towards the end. You know, in the autumn again, there will be a resurgence, either due to new variant, non-compliance with vaccine, etc., etc. So we've got to prepare ourselves for what will come back to us in September, October, really.
Brilliant. Thank you very much, Deepak. Right, I'm cautious of the time, and we do still have two other items to go through. So we'll move on at this point then to Sharon Pickering, who's going to go through the big conversation with us.
Thanks, Chairman. I'll just try and share a slide pack that I prepared for the board today, and it would be helpful if people could tell me whether they could see that.
Yep.
Yes, I can see that.
Yeah. So I hope that it'll now go to a presentation slide. So just to, you asked us to come and talk to you about our big conversation. And I think it's important to note that we have undertaken this huge engagement that we've called our big conversation, but that was we did it to help us co-create our strategic framework going forward. And we felt that this was necessary to sort of review, refresh, revise our strategic framework due to a number of things. I mean, clearly the board will be aware that we've had a number of significant events, sad incidents over the past few years. We've also, been part of living through the pandemic and providing services and our experience of those through the pandemic. And we've also had some significant leadership changes, particularly with the arrival of our new Chief Exec, Brent Kilmurray. Sends his apologies that he couldn't be here in person to do this presentation. So I guess as Brent was doing research about the post and thinking about applying, and then once he had been appointed, preparing for actually joining us, if he was presenting this, he would tell you about the messages that he picked up through that preparation, really. And what he picked up was that we weren't consistently getting it right for our service users and their families, for our staff and for our partners. So that's not to say we weren't getting it right at all. We've got some really, really, areas of strong performance and where we get really good feedback. But I guess what he heard about was what he would call unwarranted variation. And so when he came into the organisation, he discussed with the board this idea of refreshing our strategic framework, and the board absolutely recognised the need for that. So in doing that, we wanted to make sure that that strategic framework was co-created and wasn't just produced by the board itself, but actually was co-created with our service users, carers, partners and our staff. And so we engaged in this what we called our big conversation, and there was a number of stages through that. And up until October, November time, we'd had, as you can see there, over 2,000 people participated and over 35,000 contributions to that conversation. And every single one of those contributions has been read and formed part of the analysis. And when we started this journey, we employed an independent company to help us with this. And part of that was because, they had an electronic platform that we could use, which made that analysis easier, but also because we wanted it to be seen to have a level of independence in terms of doing that analysis, and people feeling that they could contribute without feeling that people in the organisation would know who it was that made that statement. So we were keen to make it as independent as possible. So these were the stages that we went through, which resulted in our draft strategic framework, which I'll come on to in a minute. But we've also just recently undertaken another our big conversation. So we don't expect this to be the sort of end of our big conversation. We expect in the future that we'll have other big conversations based on different things, but this particular one was based on the development of our revised strategic framework. So across the participants and contributions we got, I mean, this slide gives you a whole load of sort of bar charts and things to show you where those responses came from. But the important thing is really to get across the bit in the blue on the right in the box. And this is that, there was a representative spread of input from the different groups I've talked about, staff, service users, and that no one group or mindset dominated in the feedback that we got. There was actually quite a lot of similarities and and shared views that came across in the big conversation. And what also that we are confident that data saturation was reached. So that means that actually if we'd got another 1,000 people to engage, we don't believe that that would have sufficiently changed the analysis that we came out, because there was quite a lot of consensus about those narratives, as I've already said. So the having got all the feedback that we got through our big conversation and having completed that analysis, there were these 7 core narratives that came out. So there was something about saying...
Sorry, yeah? But the slide's not changing, so we're still on the first slide.
Oh, I apologise for that. Sorry. Let me see if I can stop saving it. Has that changed now, Dominic?
It has, yes.
Oh, sorry, I do apologise. And maybe, you know, I'm more than happy for the slides to be sent out after this meeting to committee, to the board members, Amanda, if that's possible, so that they'll be able to see that. So I apologise. What I'll do is I'll try and make this a bit bigger so that people will be able to see it without putting it into the true presentation style. So, as I said, there were 7 core narratives that came out. One was about the organisation needing to be clear what we were here for, what was our purpose, and from that, what we heard was that we needed to be clear what type of organisation we wanted to be in the future, what was our vision, and a lot of feedback that, you know, we weren't at that level, at that vision. You know, we weren't actually the type of organisation that people were telling us we ought to be and they wanted us to be. People told us gave views on what values and behaviours they thought the organisation should implement and staff should demonstrate, and that we needed to prioritise the development and transformation of care and systems by making 3 big commitments, and they've been translated into our 3 big goals, which I'll come on to, and how it will look if in 2026, in 5 years' time, if we actually made progress and achieved this strategic framework. So just briefly, because I am aware of time, in terms of that strategic framework, what we identified is that purpose, which is the top on here. This is why we do what we do, because we want people to lead their best possible lives. And the bullets underneath that were the sort of summary of what people were telling us we weren't getting right. So, and that links into really what Brent heard when he was preparing for joining the organisation, that we weren't providing a good enough experience, we weren't consistent enough about that we're not always easy to collaborate with, that our speed of response is sometimes too slow, etc. So really this was a real mandate for change, really. So we've created a new idea of what kind of organisation we want to be, and in sort of management speak, this would be our vision. And it's really about that co-creation being core. So co-creating safe and personalised care that improves people's lives. We want to listen, learn, improve and innovate, and be respectful, compassionate and responsible. And that really brings me on to our values. So these were the values of all the feedback we got back on how we should behave and what our values should be. That these could be grouped into these 3 things, that we need to have a value around respect, around compassion and around responsibility, and the sub-bullets under those sort of demonstrate the behaviours that would go along with those values. And then we identified 3 strategic goals. So the first one is about, you know, co-creating a great experience for our patient carers and families. So this is not about TUV or management in TUV doing this ourselves. This is about co-creating with carers, service users, staff, but co-creating that great experience for patients, carers and families. And there's some bullet points there about, you know, what we expect, what those people we want them to experience if we get this right. There was a goal around co-creating a great experience for our colleagues, so that if you work at TUV, those were the things that you will feel by 2025. And then also a goal about being a great partner, because we recognise that, you know, perhaps we've become, well, not perhaps, the message that we got was that we'd become rather insular of late, and we needed to sort of look external and be more supportive of partners, etc., and work in the system. From the feedback we've got, and to sort of almost move into implementation in terms of if that's what our strategic framework is, how are we going to deliver that? We identified 5 key areas to focus on, and these will be the key areas that form the backbone of our business plan for the coming 2 to 3 years. So they are about co-creation at our core, having a clear clinical approach, so we're absolutely clear of the clinical standards that we expect and where it is acceptable to have variation and where it isn't, and how we're going to work with the wider systems to make sure that we're all meeting the needs of people with mental health needs, a learning disability or autism. We want to have a key focus on being a great place to work, a key focus on playing a leading role in our system, so offering the system our expertise and how we can support the system, and working collaboratively with the system, and also having an empowering infrastructure. So this is about making sure that our corporate services are absolutely wrapped around our frontline clinical services and supporting them in delivering on the strategic framework. And we've started co-creating objectives and milestones for these 5 areas. And recently we've gone out to another stage of our bid conversation where we shared all those milestones for those 5 areas, and we asked the crowd to help us refine them. So we asked people to tell us what's strong, wrong or missing. So we've received another 5,000 contributions on those milestones, and they're currently being analysed, and we will refine those milestones based on those contributions. But one of the big messages we've heard is that there's something about language and our overuse of management speak in those milestones, but also in some areas, you know, there's a bit of scepticism, I think it's fair to say, about whether these things really will get delivered, and, you know, haven't we been here before type thing. And we recognise, therefore, that it's really, really important that we demonstrate some early wins, really, to give people confidence in where we're going. So that's the presentation. I'm happy to take any questions, Chair, if there's time.
That's brilliant, Sharon. Thank you very much for that. I've got Margaret Wren wanting to come back in. Are there any questions or comments from members? We've got Councillor Thomas.
Thank you, Chair, and thank you, Sharon, for the presentation. And I think the presentation really covered a lot of the priorities that I would anticipated being there. And I think for me, and from sort of like the Health Watch perspective, and from the perspective of people who I work with who are looking for support with their mental health, I think that the sort of right care, right place model is absolutely spot on. But I think the other element that needs to come into that, and I think it's probably there implicitly, but probably deserves a mention in itself, is right time as well. Because so often when we come across cases around people trying to access mental health support, it's getting that right time as well, getting support to people at the earliest possible opportunity. And I think that in itself really is a big priority if some of those other things that you were talking about are going to work in the way that you were hoping for. And again, thinking about some of the things that we've already talked about today, the important role that the community and voluntary sector and other partners play in enabling TUV to be able to facilitate some of that low-level support that often gives people that assistance with their mental health before the condition develops into a one in which they maybe need a different type of support. So I think that it looks to me to be hitting many of the marks, but I just would go back to that issue about getting the right time in there as well, because for people who have a mental health issue which they're wanting help with, that timeliness of it is so important as well.
Thanks, Councillor Thomas, and I absolutely agree with you, and certainly in that although I haven't shared with you obviously all the details of the milestones of those 5 areas of focus, what you've talked about actually appears in 2 of those 5 key areas of focus. So really understanding the overall model of care at a local place, and how the system itself delivers that, not just how TUV delivers their bit or all of it, but how we interface and get a real sort of systems approach to delivery is absolutely a clear part of that clear clinical approach area of focus. And then the other area where this comes in is the one about playing our role in sort of system as a leader in the system. And one of the milestones around there is about how we work with the system, and particularly public health, to help support that sort of early intervention, health promotion about mental health, but also addressing the stigma as well, Councillor Thomas. So we've got it sort of, although I haven't shared you that detail, there are a couple of places where it appears in what will become the business plan.
Do you want to come back, Stephen?
Thank you. Yeah, can it come back in? I think, again, and I agree with everything that you've said there, one of the things that can be so difficult for people who are accessing support with their mental health for the first time is, I think, exactly what you referred to there around the stigma that still exists. And I think very often for people seeking help with their mental health, it can be a huge, huge thing for them to do. And if that support isn't forthcoming straight away, then that can really knock the person back and knock their confidence to be able to try and access support again. So I think you're absolutely right. It is such a big priority.
I agree, and I think, earlier Deepak talked about some of the benefits of, some of the good things that come out of COVID, and I actually think the greater awareness and people talking about mental health, as a consequence of, all of our mental health has been impacted in one way or another because of COVID. And I think that, again, there's been lots of horrendous things that have come out of COVID, but I think that greater ease at which people are talking about that now, I think is really positive, and we need to build on that.
That's great. Thank you very much. Are there any other questions or comments from other members?
If people have got other comments when we circulate the presentation, I'd be more than happy to take them, Chairman.
Yeah, that's brilliant, Sharon. That's actually what I was just about to ask. If there were any comments or any other feedback people wanted to make afterwards, how would do you want that feeding in?
You can just send them to me or to Dominic, one of us. I mean, if it's easier for people to send it to Dominic because that's the person you know better, he can forward them on, or Amanda's got my email address, so it can be sent directly to me.
That's brilliant. Thank you very much then. Thank you.
Thanks.
Chair, before we move on, can I just ask Sharon, will you be presenting back to the Mental Health Forum on a regular basis to give updates with regard to the progress that's being made?
Yeah, we certainly can. I mean, the way we see it panning out is that, we were really keen to get this done by sort of January time so it could feed into our business plan, because the business plan is basically, these are the things we're going to focus on in the coming year, the new things, not the day in, day out things, but the sort of transformational things, so we can bring sort of updates on how that's going in terms of are we implementing it. And as I said, there definitely is some scepticism about, but you know, I think we're really keen. You know, we've got a momentum with this now, and we're really keen to demonstrate that we can, you know, we can make a difference.
Thank you.
Great, thank you very much. We'll move on to the final one then. It's Karen Hawkins, and it's the ICS proposals from the CCG.
Great, thank you, Chair. I'm conscious of time, so I won't take up much of your time. In relation to the update that's been provided, the paper that was provided to you just set out what the next steps in building integrated care systems looked like, and the consultation document was published by NHS England in December. Obviously, as a CCG, we're a key stakeholder and impacted by the proposed changes. So the consultation document set out the requirements in terms of what they were consulting on as a system as we move forward, and how, as a CCG, we approached our response to the consultation, undertaking views from our staff, our governing body, our executive committees, our council of practices, and also our primary care network. Really importantly, our Chief Officer, Dave Gallagher, has liaised with our social care colleagues and the Chief Executives across our local authority areas that span our footprint of our ICP across Tees Valley. We did submit a corporate response on the 8th of January to the proposals that were outlined. And obviously, when we wrote the paper for the purposes of Health and Wellbeing Board at the time, which was on the 4th of February, there had been no update provided. Subsequently, you'll be aware that the white paper and the bill has been published. It was published on the 11th of February, setting out the proposals that will be proposed to government in relation to the measures that will be taken forward. From a Health and Wellbeing Board perspective, interestingly and importantly, the legislation that is being proposed obviously outlines some of the areas around making sure that things remain at place-based, that there's joint working at place level, and that also this is about bringing systems together to support integration and develop plans, ensuring greater collaboration between the NHS and local government, and the proposal of integrating and integration within the NHS. So there's two forms of integration that are being underpinned by that legislation, and those are the two areas. There is also the duty to collaborate, and the health and care partnership of bringing the systems together. The document's quite a hefty document. It's an 80-page document that sets out the requirements, and we can certainly send a link to that if partners haven't already got that since its publication on the 11th. That's all I intended to cover, other than Dave Gallagher has committed to provide updates as they're working through with the integrated care system that we currently have in the area, what this may mean for the future. No plans have been yet developed, but has committed to ensure that he keeps your chief executives and also the Health and Wellbeing Board updated in relation to plans as we move forward. But there's no further update as of today, Chair.
Thank you, Karen. I must admit, this is one I'm actually keen to hear from some of the partners on, because from a local authority standpoint, there are some serious concerns with the current proposals around the ICS, not least with the size and the geography of the proposal that's been put forward. For those who aren't aware, the current ICS, which we would end up being a part of, covers the whole of the North East and North Cumbria, which is over 3 million people. And that's more than double the population size of the South Yorkshire and Bassetlaw ICS, and it's the biggest one in the north of England, bigger even than Greater Manchester, which is the next closest. And obviously from that, the size-wise, it raises the natural concerns of how can you ensure you're getting a place-based service, and how can you ensure that small places like Hartlepool, small local authorities, are going to have a fair crack of the whip. How can we ensure that the concerns we have here, which may be very different to other areas of the northeast of England, and indeed certain parts of Cumbria as well. Unfortunately for me, consultations have unsurprisingly been woefully lacking from a local authority standpoint. And despite local authorities being the statutory bodies responsible for place, and often were the closest to the levers of the wider determinants of ill health, the whole setup so far feels to me like a collaboration of NHS organisations with local authorities, kind of, well, just loosely talked about in the last consultation document, and we got a whole 2 paragraphs in the whole document. I mean, if I'm being honest, maybe I'm just being sceptical because of some of the people involved, but right now it feels like it's an exercise of empire building for some people, while the rest of us have been busy doing other things. And I'm really keen to understand where other partner organisations are coming from, especially given that Tees Valley CCG has recently been what's the word I'm looking for, restructured and created, and then we've got the local PCN, and obviously your organisations haven't had time to take full effect yet, and to see what great work you would be able to do on a more local level. Anybody? No.
Chair, if I just pick up a couple of your points. Obviously, Dave as the Chief Officer for the CCG currently has been absolutely clear in terms of there needs to be a local approach, and that was the CCG's view in terms of response to the consultation. I think what was helpful in the legislative document and the bill that has been published, it's really clear that the legislation should avoid one size fits all, and that the flexibilities for local areas to determine the best system approach in terms of place-based joint working and place-level commissioning was clear within that, and that commitment remains even within the ICS in relation to place and a place-based focus. We can certainly, I can take from the meeting to ask Dave to make sure that there is representation as we move forward through the Health and Wellbeing Board to present something to the Health and Wellbeing Board in relation to the potential future changes. But the document itself does lend really well now in terms of legislation and changes that it is place-based and that it shouldn't be a one-size-fits-all as we move forward, whereas the consultation document didn't really outline that in such detail. So I hope that reassures you in some way in terms of the documentation.
Thank you, Karen. I mean, I must admit, it's not so much the more local aspect of it. It's those who are controlling things at the top. The consultation and even the stakeholder engagement event that was held more recently, there was no real engagement. It was still all the way through, this is what we're doing, this is what we're doing. There's no actual engagement in there. And I do fear that certainly local authorities will be steamrolled into something without any meaningful consultation. Fiona?
Yes, I can completely understand where you're coming from, although obviously I can't comment on the recent event because I wasn't there, but I have happened to be at a couple of ICS briefings recently, and I've got another one in the diary specifically for federations at the end of this month. So I felt as cautious and nervous, I think, as possibly some people on this call have. But the theme that came out from my recent interactions was very much of empowerment at a local level. And so I did leave those conversations feeling a lot better than when I joined them, if that makes sense. And I just wanted to share that. I did come away with thinking that as an integrated care partnership, we would have a lot more autonomy locally to decide who does what and where decisions are made than I previously thought we would. And so I'm feeling cautiously hopeful now.
Hopefully we get the same reassurance coming through then at some point, because it hasn't been that way so far. But thank you, Fiona. Councillor Thomas.
Thank you, Chair. And I would echo the remarks that you made earlier there. And I think one of the really important things for me is in order to get the experience for patients, care service users right, the interface between health and social care has to be right. And I think for that reason alone, Chair, I think you absolutely hit the nail on the head with regard to the consultation, the engagement and the involvement that needs to happen. And I think so far there has been a lack of inclusion of the local government side of the equation. Local government is a key commissioner of social care services and has a massive role to play in ensuring that the social side, the social care side of the equation that I talked about is as effective as possible. So I hope that is corrected going forward, and I hope we see greater involvement and engagement as things develop.
Thank you, Councillor Thomas. I don't see anybody else with a hand up. Is it John? No. Great. And that's it then. So thank you all very much for your attendance. It has run over slightly this morning, but can I just say thank you to everybody, and especially for those who were able to stay with us. It's actually been lovely to have such engagement in the board today as well. So thank you all very much. I don't believe we will meet again for this municipal year. And so can I just take the opportunity as the current chair to thank you all very much for your participation over the past year. I don't know whether I'll be the chair next time around, so if not, again, thank you all very much. Look after yourselves, and I've really appreciated it.
Thanks, Shane.
Thank you.